So in this subchapter on mitral regurgitation, we'll talk about other causes of MR. Other primary causes, in other words, causes which are related to a structural problem of the mitral valve. Which issues will we touch? First of all, degenerative changes, rheumatic heart disease, endocarditis, congenital malformations of the mitral valve, and finally even drug-induced mitral regurgitation. By far the most common cause for mitral regurgitation is degenerative disease. It's an aging process. So what you will find is annular calcification, thickening of the mitral valve, thickening also of the papillary muscle, and mitral regurgitation. Typically, regurgitation is not severe. If it is severe, look for a reason. Look if there maybe is a flay leaflet or a destructive mitral valve, for example, in the case of endocarditis. Even though rheumatic heart disease primarily causes mitral stenosis, we do have many patients who also have regurgitation. The typical features of rheumatic heart disease are seen here. We've studied these already. Doming of the anterior leaflet, thickened leaflets, and here's regurgitation. The mechanism can vary. Sometimes it's a destructed valve, sometimes it's retracted leaflets which cause restriction, but it can also be a combination of endocarditis, which is secondary to the rheumatic heart disease process. A further cause is endocarditis. Endocarditis can lead to significant destruction of the valves. We see flay leaflets, we see perforations, the valve simply melts away. Here's an example. We have a large vegetation on the mitral valve, and we also see significant regurgitation. You'll hear much more about endocarditis in the corresponding chapter. Which types of congenital abnormalities of the mitral valve can we have? Chordal abnormalities, papillary muscle abnormalities, and a cleft mitral valve. Here's an example of a patient who has an abnormal long anterior and posterior leaflet. Look how far within the ventricle we have the line of closure. And we also have moderate regurgitation. Probably there is some abnormal insertion to the papillary muscle as well. Here's an example of a so-called parachute valve, a very rare disorder which actually should not be in this chapter but in the chapter on mitral stenosis because it more frequently causes stenosis and not regurgitation. This patient, however, did not have significant stenosis, only mild regurgitation. But I want to show you the typical abnormalities seen here. We have the impression that there really is a parachute here. Why? Because these leaflets insert on one papillary muscle. This is the two-chamber view. Look at the abnormal morphology of the mitral valve. This is the four-chamber view. Again, we have the insertion of both leaflets from the same papillary muscle. And this here is the parasternal long axis again. The third type of congenital defect of the mitral valve I would like to show you is the so-called cleft mitral valve. All patients who have a primum ASD also have a cleft mitral valve. Rarely will you also find an isolated cleft mitral valve. Here is an example. Parasternal long axis view, very abnormally formed mitral valve. However, many patients do not have such an abnormal appearance of the mitral valve in the parasternal long axis view. What is really diagnostic is the color Doppler, where you see the jet that goes through the mitral valve, and the short axis view, where you can actually visualize the cleft. This is the posterior leaflet here, this is the anterior leaflet here, and here you see the cleft. If you turn on the color, you see that the jet goes right through this cleft. Finally, I also want to mention drug-induced mitral regurgitation. We know that certain drugs can cause destruction of the endothelium and thereby also affect the valves and cause regurgitation. It is well established that diet drugs, for example fenfluramine, can cause valve destruction. We even know that substances like serotonin, which are very high in the situation of Carson syndrome, can cause valve destruction. There, it usually causes valve destruction primarily of the tricuspid valve. However, in the setting of a PFO or an ASD, where we get higher concentrations also in the left heart, do also see affection of the mitral valve. This here is a patient who was an intravenous drug abuser and who was on the methadone program and who injected herself methadone intravenously. This led to destruction of the mitral valve, as you can see here. We have a thickened mitral valve with restricted leaflets, significant regurgitation, and we perform TE in this patient and we can see that the leaflets are actually retracted. Of course, there's also a secondary cause of regurgitation here. We also have annular dilatation. So you see, echocardiography can help us to find out why someone has regurgitation. However, not always. There will be ambiguous situations, and sometimes we just simply can't tell. Don't forget that in some patients we also have a combination of problems. I've seen patients who have mitral valve prolapse and rheumatic mitral stenosis, so two causes might be present as well.